Dear friends and colleagues, I am very much pleased to welcome you all, and I am greatly honored to organize and moderate this session. And as we all know, that left main PCI is challenging because of large area of myocardium at risk, and the coronary anatomy is widely different in every patient. During the last decade, after the results of Syntax Nobel and Excel trials, PCI certainly has expanded its role in left main revascularization, but which technique is better remains a controversy. However, more recently, a few landmark studies, like ones from European Bifurcation Club and more extensive, like DK Crush studies led by Professor Chen and his colleagues, have opened up more suitable options and guidelines to treat left main bifurcation disease percutaneously. We are honored to have Professor Xiao Liang Chen to chair this live case webinar today. Thank you very much, Sean, for joining us today. And amongst the panel of experts, we have wonderful interventionists with a wider experience in performing left main PCI. From Pakistan, we have Professor Nadeem Rizvi, Professor Suhail Aziz, Dr. Bashir Hanif, Professor Tahir Sagir, Dr. Asad Khan. And from United Kingdom, we have Dr. Abdul Mozid from University Hospital Leeds. Another big name, as mentioned, from United States, Professor Maurice Bookbinder, and Dr. Atar Ansari, who is from United States. Thank you so much, everyone, for joining this panel. And I'm sure we all will get learning benefit from the rich experience of our renowned faculty. With the support of High Noon Pharma under the umbrella of Pakistan Society of Interventional Cardiology and Pakistan Cardiac Society, we are starting these quarterly series of live interventional program addressing the most challenging areas in coronary interventions. Our last live case today is from the first live case today from Freeman Hospital, United Kingdom, where Professor Mohammad Agred is ready with the case. Professor Agred has a special expertise in complex PCI and is internationally recognized as one of the leading interventionists in complex and CTO PCI.
Yes,
He is an international proctor, physician trainer, and a faculty member of numerous international and national meetings, and is a regular live case operator. Now, can we go now to the Royal Free Hospital, please, to join Professor Agred and his team? Professor, can we go to the Royal Free Hospital, please? Thank you.
Good afternoon.
Yes. Hi, Professor
Hello there.
Agred.
Can you hear me?
Yes,
Good
it is very
afternoon.
nice to see you in the lab. And after a brief introduction of your team, if you want, please go ahead with the case.
Thank you very much for the introduction. Just to make a correction, it's the Freeman Hospital, not the Royal Free. The Royal Free is in London.
Sorry. I do.
The Freeman Hospital is the Newcastle. It's all right. Just to make it clear.
All right. Okay.
We, of course, just to kind of give background, this is one of the biggest center in the UK and the largest volume, and we do have a large volume in here, close to 3,000 per year. So welcome to the Freeman Hospital, and I've got a great team with me. I've got my colleague here, Tariq Salim, is a consultant colleague with us in here. We have Emma and Christine and Louis here in the lab with us, and also Kate and Savannah controlling. And of course, with the great help of our AV technicians, Paul and Ahmed, we are coming live to you. So as Dr. Raza have said about left main stem, it has come a long way, and the guidelines and what we do with left main has changed dramatically, and we are doing BCI more and more. Myself, I probably do about 80 to 100 left main BCI per year, and I think it's becoming a mainstream treatment. And of course, how you approach it technically and what you do with it is different from one person to another, and data keep coming down. We took part in the ABC trial recently, the Bifurcation European Club, and which was published recently. And again, everybody has their different approach to bifurcation. So it's easy to what I chose with the case today, which I'm gonna go on to tell you today, a 66 years old gentleman with a history of hypertension and positive family history of ischemic heart disease, who has been getting recurrent chest pain and angina and has been on medical treatment, undergone a coronary angiography, which showed left main stem and ostial circumflex disease with minor atheroma in the RCA. There's a heavy burden of calcium in the left main and the circumflex. I'm sorry, there's a lot of interference in my ears. There's a background talking. Can you hear me, guys?
Yes, we can hear you very clearly.
Yes, okay, good. And so, as I said, 66-year-old gentleman, hypertension, dyslipidemia, and positive family history of ischemic heart disease with angina, who underwent an angiogram and with ostial circumflex and distal left main. And he was discussed at the JCC with the surgeon, and the decision that could be made with both, whether surgery or BCI, and we opted for BCI. And this is the case. And I thought, instead of showing you a definite bifurcation, I think the anatomy in this case is quite interesting. So if you don't mind, we could go ahead and show you the angiogram from today, and then
Yes,
we'll
please.
see what the panel is saying. So if we go for the first, go forward. Yeah. So here we are. To tell you what we've done, we go radial. Our default approach is always radial in all cases, unless there's a problem and we fail it. So this is a 6-7 radial sheath, slender sheath with a 7 French guiding catheter, EBU4. And this is the angiogram.
Right, okay.
Yeah. Sorry, there's a lot of interference. Some people talking in the background. I don't know where that's coming from.
I think everybody else should mute their mics, because whoever is talking in the background.
Oh, yeah, I think, we should, everyone, if mute their mic, then
probably Afsar can.
Yeah.
Okay. That's
all right. Okay.
So here we are. So this is the first angiogram. Next one. Next one. So here we are. We just took these pictures, and as said, the RCA is dominant and minor atheroma, nothing to speak of. So I'd be interested to hear what the panel think and the experts, how would they approach, what would think with this case.
Yes. So, okay, we just start from our younger consultant colleague from Pakistan. Asad, you have seen the picture, you know the history. How would you approach this patient?
Hi. So thanks, Dr. Mohanad, for taking time out for Pakistan. So yeah, definitely a very complex case. You can see a lot of calcium even before you inject any contrast. So it's at least moderate calcium, if not more. And probably for me, I would agree. I'll go with a 6 French guide, as Mohanad has said repeatedly that it's a right dominant system. So we can see pretty complex left main disease. It's sort of a more trifurcation disease. If I were to do this case, I'll take a 6 French guide, probably do an IVUS of left main to LAD, and then you can see a big ramus and a circ. Circ seems pretty non-dominant and small, and I think to keep the case simple, IVUS of left main to LAD, and then probably I don't think you'll be able to cross IVUS directly into that ramus, even if you tried. So probably rotablation or some sort of debulking device, depending on the availability and what you see on IVUS. If you see more than moderate to severe calcium, which I'm pretty sure you will, probably rotablation from left main to LAD, and then probably a cutting balloon or something from left main to circ, and then do a 2-stent strategy up front. The good thing here is that the ramus only has ostial disease, whereas the circ, which is again non-dominant, has a more longer lesion in the proximal part. So probably, I think after rotablating from left main to LAD, we can see the flow and see maybe if we can just do a cutting balloon at the ostium of ramus, and then do again rotablation or something if needed in ostial circ. But for me, I'll try to keep it simple. IVUS left main to LED probably will need rotablation and then wire both ramus and circ. And I think for me, probably keep it simple. Just cut the ostium of ramus and then depending on what the IVUS shows of proximal circ, if not much calcium, then just do a high pressure balloon and a 2-stent strategy. One stent into the LED and the other one into the circ.
Right. So thank you. So if I get you right, I'll just to interject here. So with single stent strategy, but you leave the circ alone, or you try it with a cutting balloon.
I think for me, I think to me, ramus looks slightly bigger. I'm not sure in this view.
So yeah, I'm just interested in what you would do with the circumflex.
No, I think it's a big area of supply biocardine. We can't ignore that. So I think we need to address this as well. Otherwise, original symptoms will stay there.
Yeah, I would do the circ. Personally, the Maurice Bookbinder again. I would treat exactly the same, but more circ and the left main LED.
Yeah, I think ostial ramus might do cutting balloon and then stent circ and LED.
Exactly.
One stent strategy, I'm not sure. I won't jail that LED. I'll probably do a 2-stent strategy.
Yes.
Okay, let's see. Nadeem, can you do you hear? If we can have your comments, please. So he's not online. Right, Sean. How do you think to approach this patient, please?
I think this is a very, very challenging case with very severe calcification in both LED and circumflex. So for this, for my personal first step will do rota for circ and LED too. Secondly, it could be classified by Medina 111 to complex bifurcal lesion because lesion length in circ is longer than 10 millimeters. So personally, I prefer to upfront 2-stent technique, particularly DK quash. Another point is for ramus, for obtuse marginal and circumflex, because they also show obtuse marginal is diseased very, very severely. So I will use a provisional for circ and obtuse marginal. Thank you.
Right, Monad, how did you approach this? And sorry, yes, Nadeem.
Right.
Okay.
Oh, sorry.
Yeah,
go
sorry.
on.
There is one more comment from Nadeem.
Sure.
Yeah, I think in this kind of a case, I would definitely first use a balloon. I'll wire all 3 balloon and then take it from there. I'd probably need to do a 2-stent strategy. I'd probably do a DK crush after preparation, probably a stent in the circ and a stent in the LED, left main LED. So I would, and then probably rescue the ramus by opening up the strut of the circumflex stent. So I would probably use a 2-stent strategy, prepare it with a rotablation probably. First with balloons and then see if it opens up well with the balloons, cutting balloon, then no need to, otherwise I'd rota it.
So you'll try with the balloon first.
Yes, there's no harm. I mean, you're not going to, because if you go with rotas up front, then obviously you can only have one wire and you'd have to choose which vessel you want to do, you know. So,
and if that's the case, which vessel would you choose?
I would probably, if you're asking me if I'm going to do a rota, which vessel do I choose? So I'd probably do a rota to the circumflex.
I think the LED has to be done first and foremost. That's the problem.
No, but then the problem is that
it's a single wire. It's not going to close down. You see, that's the most critical part is the circumflex. If you rota the LED, yes, I mean but there's not a critical lesion. There is a significant one, but I mean it's elective. One can do either way. But the
but Boris, if we do the LED first, then how would you approach it? Say, I think in bifurcation, do the difficult complex one first. So that
yes, I think it's correct. It's doable with the circ versus the LED. But at the end of the day, the patient is the best to take care of him is the left main to the LED, first and foremost. I think double wires, we could do that after rotablator and do the 3 wires and create it accordingly. So I would.
Can I ask you, sorry, what size bird would you use? If you
probably 1.75
to the LED, right? Okay.
Yep.
My only to Maurice is that I mean, there is maybe not a very high risk, but if you just rotor the LED first on and the circ closes down, then what? Because you only have one wire when you're rotating, unless you want to do a rota on and keep a wire in the circumflex.
Or you could dilate. You could first dilate the circ and OM, and then take it out and create the left main LED. At the end of the day, he has to live with the left main and the LED. That's most important. That's the problem.
Personally, I will try to avoid the ballooning pre-dilation for some flares because very severely calcified. So I will do a wire LED circuit flash and the rotor for sure, and then check IVUS for both LED and circuit flash.
Yes, I agree with this because it is important that the calcific
okay, so shall I tell you?
Need to be. Yes.
Shall I tell you what we decided to do and how it approaches myself? I always find it interesting because if you have 3 interventionists, you ask for opinion, you get 4 opinions.
Yeah, 5 people think about the 3.
Yes, so yeah, 3 interventions give you 4 opinions, and this is the beauty of this. This is a technical thing. To my mind, the circumflex is the more complex and the more difficult one, and the heavily calcified. And if I think it needs rotablation, upfront rotablation, no ballooning, nothing. It just needs rotablation. We go ahead and do it because you end up spending a lot of time, a lot of X-ray and dye, and I think you never achieve what you want to do. My colleague, when he did the angiogram, he tried to pass the IVUS into the LAD. He could not. So that kind of gave me also an indication. This used to be called the Washington test in the old days. You try to pass the IVUS catheter. If it doesn't go, you know that you need rotablation. On this occasion, we did wire the LAD and the circumflex as well as the intermediate or high OM, if you like it, because what has been discussed is absolutely crucial. What do you do with this intermediate? What do you do with the circumflex? And do I need to be intervening on this? Luckily, I will show you the IVUS. Actually, we did have the integrated system. Unfortunately, the cable is broken, so we're using the tower. So we'll show you that. We could put the camera on it in a minute, but I'll come to that in a minute. So we did IVUS the LAD, and we did the IVUS would not go to the circumflex as expected. The intermediate does have some disease, but luckily, as we could see angiographically, and I don't know if that's clear to you guys, the ostium is not significantly diseased at all. There's eccentric calcium and mild atheroma, but it's not, which in a way makes life much easier. And to me, this is definitely 2-stent strategy because the territory with the circumflex and the intermediate are large. So it cannot be ignored, and it is the most significant one, as you could see. So if we go forward, wiring the circumflex took a little bit of difficulty. I ended up having to use a Fielder XTA, which is hydrophilic, jacketed, and tapered wire to be able to get to the circumflex, as you could see in here. Next. And then, yeah, next. We'll stop there. So do you want to see the IVUS to the LAD and the intermediate? No, go back. So shall we show you the IVUS? Yeah. So can we put the camera on the IVUS, please? So can we move the? You could move the machine. Can you move the rotablation back, please, so you could see the IVUS?
So
here you, could see it.
You wired the 3 wires just for the IVUS.
This is for the IVUS because I mean we started a little early. I thought we'll do some work before. You don't want to be seeing me wiring the RT. It's nothing, no, because I think this case has a lot of teaching points, and that I was going to mention. Nadeem mentioned about having 2 wires. You can do rotablation with 2 wires. One option is to use a guide liner. It's a bit cumbersome, a bit difficult, and on many occasions I did left a normal angioplasty wire and went with a smaller burr in a big, like a 7 French or 8 French, and no problem. But if there's any bend on the wire and the burr is closed, you have to be careful because you could cut the wire. Can you see the IVUS? This is the first one, yes?
We can see it.
So, okay, so let's run the IVUS and have your comment on it. So we started from that little aneurysmal area, as you could see.
Yep.
Well, we'll clear it up. Here we go. So you could see there's a lot of calcium. Here it becomes, okay, that's the aneurysmal area. We started just behind it. And we're coming close toward the ostium and toward the left main. You can see there's eccentric calcium, obviously.
Right there.
And now it's going to become even worse. That's very close to the oscillatory LED here.
That's the
You can see
problem.
yeah. So that's where the problem, and this is the distal left main.
Exactly. That's what we talked about to begin with.
Yeah, absolutely. So, I mean,
what is the MLA of? Have you calculated the MLA of this?
To be honest, I haven't. I was scrubbed, but it is less than 5 millimeter.
Oh, for sure.
Right,
At least distally.
3 to 5. Yeah, 3 to 4, definitely.
Here we
Yeah,
go. It's
absolutely.
My question.
Let's do the next one.
Is,
Yeah.
Sorry to interject. My question is that in a poor country like ours, I mean, it's quite obvious that you can't intervene in the circumflex. If you've decided for a two-stent strategy, you're not going to stent the circumflex and get away with without much problems in the LED. You're going to have something, so it has to be LEDs. And so, is IVUS absolutely necessary up front? Is it just for sizing, or because you know that it's significant? You would need to intervene in the left main LED.
Look,
why not just
I mean, the
circ
trend,
and just then do the IVUS later?
Yeah, well, the trend nowadays is to do IVUS all the time, and everybody talk to, I do IVUS all the time and do imaging. It's not what I do. Absolutely not. My percentage usage of IVUS, even left main stem, is probably about 20% at the most, even in other lesions. I think we've done enough. If you size correctly and you both dilate correctly, I think you probably don't need IVUS that much. I might sound old-fashioned, but you're absolutely correct. The cost of this, the time, and also quite often you need to know what you're looking at, and IVUS not sometimes easy to look at. But yes, probably about 15 to 20%. If I'm going to both dilate my left main by 5 millimeter or 6 millimeter balloon, I don't think you could do any more, and that's what you see in Caucasian people if you size and both dilate correctly. So it is not absolutely necessary up front. But it's good. It helps you to optimize your result and to optimize your what you're doing. If I'm gonna use IVUS, I might as well use it from the beginning. Why only use it at the end? Because it might help you on occasion to change your strategy. This is my view.
Mohd, we have two more panelists who joined a bit late.
Yeah.
I think.
I think when we're talking this, sorry, Raz, can I just say one thing to you? When we're talking, can I continue working? Because otherwise we could speak for the next hour and nothing happens. Is that okay?
You have to say. Yeah, sure.
If that's okay, then we could carry on.
That's fine.
This is the IVUS now. This is the IVUS from the intermediate. Because I could tell you the IVUS did not go to the circ as we expect anyway. And I don't think any balloon would have gone anyway.
Absolutely.
So okay, so this is the IVUS into intermediate. Can you see it now?
Yes.
Yeah, okay. So you could see there's atheroma. I think the cross-sectional area is okay, and the ostium is going to come up shortly. Luckily, it's not, there's some disease in calcium. This is about 4.3, and I think it can be left alone. Here we go, come to the ostium. So I think it's reasonable to assume that it's going to be okay. But I wouldn't hesitate when I dilate the circumflex. Now we could get the camera back in here on me, please. When I do this, I wouldn't hesitate to just do the ostium, maybe with drug-eluting balloon, and not to put a stent in it, just to make sure that we reduce our, the amount of metal in there. So now, so can you see the angiogram now? We go back to the angiogram.
Yes, we can see clearly.
Go forward with the angiogram, please. So my plan was from the beginning to rotablate, and because this is
what size? What size for the?
This is what I was going to come to. Quite often, in 98% of my cases, I use a super extra support rotawire because I think it gives you that little bias. And in this case, because of the severe angle, I went with the floppy wire and 125. 125 burr, hardly I ever use it again. It's only severe tortuosity in cases like this. So this was 125 burr. Go forward. And the speed was 185, which I usually do for the 125 and 150. We did 3 or 4 run, and there was some deceleration as you would expect. And then everything became okay. The polishing run was very smooth and nice. And there we go. Next one. And as you can see, there's no wire in the LED. I wasn't worried, particularly also after I saw the calcification and how stable it is. So now we've done the rotablation to the circumflex. I am going to take the wire out because I'm comfortable that there's no problem there, and put it in the LED and rotablate the LED.
It will be a bigger one, right? It will be 175 perhaps.
Well, I'm going to
for
take
the
a 2.0
LED?
to be honest. I'm going to take a 2.0
yes.
straight on.
Yes.
Yes. Because I think looking at the IVUS and what we do,
Yeah,
I could
the
take a
diameter is more.
175,
Yeah.
probably
Yeah.
not going to touch the side. And this is what I find interesting occasionally with people doing rotablation. You take a 125 burr in a big artery, a 4.0 artery, and you run it up and down. And then you think, oh, the stent is not expanding, or I still need to use my IVL. And that's, I think, a huge cost. So you need to size the burr correctly, at least 0.7, 0.8 of the artery. So here, I'm just going to make sure that when I take the wire, the soft wire out, the circumflex is okay, and then I could take the wire out.
And maybe
then
we
we'll
will
rotablate
talk about IVL as well.
Sorry?
Maybe at the end we will talk about IVL, when, where, and how, in addition to potential.
Yes, this is important.
To be honest,
yes.
Yeah, a case like this, you could consider IVL from the start, particularly for the left main, but for circumflex, I think it will not go. Because let's not forget the IVL balloon is quite bulky.
Correct.
This wire is damaged.
I'm talking about the left main LED, not the circ. Okay. I agree with you with the circ.
Yes.
So
but it is not
for the, yeah, go on. It's not deliverable. For the circuit, might not go. So I'm just going to do this, change the wire. Go to cranial view, please, to do the LED. So yes, IVL would be suitable here because it's more than yes.
Mohamed, this is Bashir Hanif. Sorry, I joined a little late.
Hi, Bashir. Hi, yes.
Hi, how are you doing? My question is like I was going to ask, and you mentioned briefly, but in this like 3.0 or 3.5 even LED, do you think 1.25 rota is going to help you at all to facilitate your
No.
I wouldn't waste my time.
Sorry, he mentioned 2 millimeter. He mentioned 2
millimeter. Yeah, 2.0.
Oh, 2.0, okay.
That was
but even in 2.0 in a 3.5
the 1.25 the 1.25 I took it to the circumflex, and that's all what I did. But for the LED it's not suitable. It's not. If it were a little bit more severe and more, the lumen is narrow, then that's a different story. But I think in this case, no, definitely not.
But I think still IVL can be. One can argue with the IVL that probably that is one option in this case.
Yes,
for
I
LED.
mean, then this absolutely for the LED, and I wouldn't be surprised if we at the end using the 2.0, because you saw how big this LED is. If we still needed something i.e. the IVL to get this better. So okay, go up there.
But rotoblator will be better, I think, at the beginning.
Yes, yeah. That's exactly what I think, and this is why we are proceeding with this, to be honest. So we're just gonna exchange this wire because I couldn't get the rotor wire. This is also one reason why using the. That's not coming. Okay. So I'm just doing a trapping balloon, and then I could exchange for the put the micro catheter in, and then exchange for the rotor wire here. And that's what we are going to do. Now there's an area in the middle of the, which is the diagonal there. Okay, come down the balloon. So that's the micro catheter coming in, and I'll take the. Can we move this oxygen tube away, please?
Are you going to take the circ out?
Yes.
Okay.
Yes. I mean, again, this was mentioned. You can't use 2 as you can, but if there's severe tortuosity, you probably, and the wire is close to the burr, it's not advisable because you could cut the wire, and this happened to me before. But often you can, and if you are stuck and you don't want to take your wire out, you use a guide liner.
Yep.
However, doing a guide liner will limit you in the size of the burr, and it's really cumbersome with all the gear in. So let's come down. Take this away. So, and then in cases like this, again, I mentioned this briefly, often I would use an extra support rotor wire because it gives me a little bit of a bias in a big artery, and when I go with the burr, it usually helps to. Hold on to this wire, please.
I totally agree with you. This has happened for 10 years ago, and this is exactly what we have done. Much better.
Yes. And we now have of course, we have the Rota Pro, which can be done by one person. Although I still like the legacy one because you've lost your foot now. You only have 2 arms to use it. And the legacy one, you could use your foot as well. But, you know, it's still good. So here we go. So I'm exchanging to the floppy rotor wire. Now, even this is a turnback spiral, but I thought the circumflex and the LAD are quite resistant. The turnback spiral would not advance any further than this. See where it's stopping on the angiogram? It will not advance any further, so, which is fine, because I thought that area of the diagonal is disease and a really significant disease, but we're not going to touch it for now. I'm just going to do, look, yeah, I'm going to leave it. Even trying to retrieve this microcatheter, my guide is being sucked in and pressure dampening. So I'm going to just try to do this again to move the guide out. And I will take this microcatheter. And yes, I'll change to a big burr. Can I have a 2-0 burr, please? So for the big burr, we're going to go with the lower speed. I usually put 150 to 155 at the most, in comparison to 185 for the smaller burr. So let's have a 2-0 burr, please.
Yeah, it's been difficult sometimes. Less than 1.5 or 150 is not a good idea. You should keep it above 150.
Yeah, I mean, 150, 155 usually for the bigger burr.
Not do it lower. Some people do
yeah,
it lower, and
I know.
calcification and the problem.
This came from the old studies that were done with the 145, where it showed a little less heat and a little bit dissection. But I think this was in the era where we didn't have the dual antiplatelet therapy, all the preparation that we have for currently. So I think it's probably outdated. But I would still advise for the bigger bird to be a little bit conservative and not to go too high. Yeah, probably 155, 160. I would accept that, but no more.
100%.
Just open the drip for me, please. Again, I mean, I find rotablation is one of the adjunctive devices that you cannot do without. I think it's very, very helpful, particularly nowadays. We are dealing with you know, elder generation and a lot of calcium, a lot of complex disease. So
older people have the difficult deal. That's why rotablator works very well.
Yes, absolutely. Yes, we have IVL. It's you know, it's revolutionized what we do, but it's difficult to deliver. It's bulky. You still have to prepare, but it's a very, very good addition. Obviously, I use laser quite frequently, and yeah, so whatever is needed here is available. I'm privileged and lucky to work in a place like this where everything we need is available, and we do use it a lot. And this is why we treat quite a large cohort of complicated patients. That has become the norm. To be honest, sometimes you look for some easy cases sometimes, but there we go. This is all what's on the list. CTOs and rotablation to left main and so on, but it's enjoyable and it's lovely. Right, so we're gonna take the Dynaglide off. Okay, 155 gone.
Do you remove circumflex wire?
Yes, I have, yes. Okay, stop there. So, I mean, I don't know how people do it, but if I could show you, I usually don't screen when I'm putting my burr in. And incidentally, this is a 7 French. So the teaching has always been that 7 French does not accommodate 2.0. It does only if you use the launcher, because the launcher has got at least a 0.03 millimeter extra. So you can't do it.
So just those Boston Scientific Voda 7s, they accommodate a 2.0 burr as well.
Yes, so I think that you have to use 8 French is incorrect, and you could use it. The only problem with it is at the ostium, when you come to take the burr out, okay, let's leave it there. Okay, stop there. When you come to take, it has to be really coaxial. Otherwise, sometimes the burr could kind of damage the tip of the guide, but that's easy to overcome. So basically, again, often I wouldn't even, so we're going to start just...
By pulling it back and then pull it out will be the easiest.
Yeah, absolutely. So and it's the specking technique where you come to the lesion, let the burr work and come out, and that will affect the calcium. Often, you know, I think 15, 20 seconds is quite okay, unless you have a lot of calcium and a lot of problem. But I think it's usually what... Okay, store that. Yes, only that area that's going to be the problem, but we will run it through. There is a little deceleration down to 145 and 140, and the orange, which is the new thing now with the, you could see the bird jump forward when you do this, but that's where you really have to be patient. The Rota Pro gives you that orange color when it decelerates, and then red if it's more than 5,000, which is not supposed to happen in theory. And it's quite good. So
take your time.
Absolutely. I think this is the thing. Patience with root ablation is really paramount. And I see people doing this with the, and I don't understand where that technique comes from, but
needed.
it's just incorrect. To do this is not right. You get the burr to the lesion, let it work 2-3 seconds and come back. 2-3 seconds and come back. If the patient tolerating it, no bradycardia, everything is okay, you could burr a little longer. But doing this,
you're 100% correct.
So yeah.
But sometimes the blood pressure drops, hypertensive. So are there any predictors that to avoid hypertension?
Okay, so this is very interesting. I recently reviewed a paper that, to be honest, this is not, there could be a true drop in the blood pressure. Often what you find, your blood pressure is okay. The minute you inject the dye, because of the shaft of the root ablation, because of all what's happening, the pressure gets blunted and low. You just really have to be aware of this. You could flush the catheter and the pressure will change. But if it is a true drop in the blood pressure, then it's usually no flow or really a vasovagal reaction. So you have to be wary of that. But quite often, I mean, this happened here. The minute you inject dye, you find the pressure wave has changed.
And it looks like the 2O is moving well.
Yeah, now I've gone through the first hurdle in the left main. There you go, just a little test there. Store that. Now I think 2O for the distal part is a little bit too big. Yes. I think there's no point of trying to force it that way. I think I'm going to leave that part alone. It's the left main that's my main concern, and I think I'm going to just leave it there. If you want to,
don't do it with a diagonal. Leave it be.
Yeah, absolutely. That's what I'm going to do because it's just not. Perfection is the enemy of good.
100%.
And his left main and circumflex will be more than good to allow him to be asymptomatic.
100%.
So again, I don't need to screen here. All that I'm doing, just the O-ring is open and I'm pushing my wire in, and I don't need to screen at all. On Dynaglide, in theory, it should be no friction, and the burr should come out and the wire stays in place. Just push on the wire, as you can see, and the wire will stay in place and the burr will come out. This is what happens with the with the 2O through the O-ring. Okay, stop the drip, please. So the root ablation to the left main and LED is done, and now we're going to wire both and just do a normal angioplasty because I think our lesion is prepared and done. I think I could offer to do an IVUS before we do but I think I'm going to go ahead and just carry on because do we have an hour or an hour and a half transmission? I can't remember.
1 hour.
Hafsar? 1 hour. Okay, so we have 20 minutes. Let's just get on and do the. I thought it could have been a 1 hour and a half. But anyway, we'll try to get this sorted out quick. Store that. Let's have the Fielder FC.
So by the way, you can't read IVUS for ID and check IVUS for SIR.
Yes, I mean, this is what I just asked the question. To be honest, I'm just going to go and do the angioplasty and then we could do the IVUS at the end once we stented, because I'll be interested to hear from you guys what stent strategy would you use, and I'll tell you what I'm planning on doing anyway.
Larger is the better.
Of course. I mean, this left main is at least 5.0, and I've got the 5.0 stents ready, 5.0 stent ready in the background.
100% correct.
I'm talking about what would you use as a strategy? Would you do a T? Would you do a DK crush? Would you do a kilot? We do have a size discrepancy here from the LAD.
DK crush is mostly
from the left hand.
Absolutely,
yeah. Easiest,
100%.
But probably a little longer time than the rest, but it is a very good data. I mean, I said we took part in the EBC trial, and as you can see, and I in fact, actually, I recruited the largest number of patients for that case, for that study. But I agree, DK crush is probably okay. And though in this case, I am not planning on doing a DK crush. I'm planning on doing a reverse T, because I always find it's a 90-degree angulation, although the wire might change it. And what I usually do is, I'll take the fielder FC. Okay, I'll have a fresh fielder FC, please. I usually put the left main and LED stent in, and because then I'll have my landmark, I could bring my osseous circumflex stent and really know exactly where it's going to drop, so the ostium is covered. Alternatively, and we have published this recently, where we use our IVUS guidance, particularly for ostial left main. So what we usually do, we put 2 wires in the LED or whatever it is, and we put the stent into the left main, then the IVUS next to it, and position the IVUS at the ostial left main, and then bring the stent until we see it on the IVUS. And once we're happy that it's the ostium, we take the IVUS back, making sure the stent stays in place, and then deploy it. And I said, we published this, and now we're doing it quite frequently, and we're getting really the ostium covered without any problem.
Totally
So
agree with you. We've been doing it exactly that.
Yeah. So, and I'm, it's a very good way to ensuring, because I hear this phrase, "Oh, nail the ostium," and angiographically, there is no chance in hell that anybody knows where the ostium is. The majority of the time. Come back to the echo, please. On occasion, you might say it. You're looking at a 3-dimensional structure and 2-dimension image. There is no chance. And I have many examples where, particularly with the, say, diagonal or LAD or circ and LAD, where you think you've seen the ostium, you go to another view and it's like miles away from what you think. So just have to be careful how we look at the ostium. And this is why we sometimes fear. So using the IVUS could help you quite a lot. So we have a dissection in the circ, but that's okay. This is what we've seen from the beginning. So get into this. That's going to go to the OM.
What wire are you using right now?
This is Fielder FC. I know it's hydrophilic, and sometimes if you have dissection, you try not to. A little test there, please. But I think you could see it splintered everything, and we opened it up.
I like the
Can I
fielder.
have, yeah. I mean, Fielder FC, they're more or less the same. Although now the Fielder FC supposedly is replaced by the Cyan Black, but they're all fantastic wires. And I've got a Cyan Blue in the LED. This is something I usually do for bifurcation, where I would use 2 different color wires, so I don't have to bend or the end or anything. But you could always do that. Can I have a 3/0 by 15 or 20 non-compliant balloon? 20 will do. 3 or 20 non-compliant balloon. I'm using a 3/0 just for the circumflex, and that will affect the left main. I think we probably need to take a bigger one, maybe a 3/5 angiosculpt or something to the left main. And yes, so yes, my plan is to stent from the ostial left main into the LAD and then recross into the circumflex, although this might not work if this dissection becomes a problem. So we'll see.
Murad, what was against mini crush? Because you see, it would probably be more convenient in this situation.
Yeah,
mini
it
crush.
is more difficult. Yeah,
You know what? I'll tell you what. I don't do crush and mini crush or reverse crush. I just don't think it's the right thing to do. This is my view. I know a lot of people do it and believe in it, and this is the beauty. I mean, the bifurcation. This is why we never have something. We never have a proper bifurcation stent, because it's anatomy differs from everybody. Okay, go up there.
So you don't crush.
And I don't crush. I just think it's there's better ways of doing that.
I would take it as high as I can. I think this is most important for you. So go up to 2. Maybe almost 3.25, just to make it bigger.
Up there.
Across.
Yeah, I mean, we're going to 16 atmospheres, so.
What balloon is this?
Okay. So the balloon ruptured. Come off negative. The balloon ruptured. So we still have obviously. So we're just going to make sure we take a little test to make sure we're good here. Here we go.
Perfect.
Yeah. Often that, I mean, they still have a speck of calcium because the calcium will be fractured now. Can you give me an angiosculpt 3/5 by 15 or 20 angiosculpt, please, if we have it here.
If you have
20. I use angiosculpt frequently, and that's sorry. That's fine. 3/5 10. Let's not waste time.
It's a 3/5 for the circumflex.
Yeah, I'm just going to go in the ostium. I won't go too crazy with the pressure. I think this is a 3.5. When we IVUS it, it's going to look bigger than 3.0. Because you judge that from the size of the left main, to be honest. The left main is huge.
And you can
it's
see
not
the the LED also is much better now.
Yeah,
You see how
absolutely.
you
So I
finish
think, yeah.
the roller.
Baseline angiography suspected the presence of calcifying nodules. So, from my personal opinion, even after rotor, I prefer to recheck IVUS for sure in this case.
Yes, and also to make sure that it has been properly debulked.
Yeah,
Right.
I mean, absolutely. I've got no problem. I said, I'm just trying. Of course, here you go. Just go up there to 8 atmosphere.
We can squeeze 5 minutes from question, so 5 minutes more to do if you want to do an IVUS.
As you could see that it's expanding, but we could come down. We could IVUS it. I've got no issue, none whatsoever. It's easy to do, and just make a little test here, make sure all present and correct.
So this
Here
was
we
a
go. That looks
3.5
good.
balloon. Excuse me, this was a 3.5 balloon to the circumflex.
This is a 3.5, yeah, 3.5, 10 angioscalp.
What atmosphere did you do?
We did 8 atmospheres to start with.
Yeah, one question.
I think this is.
And that's why also you did not worry about the OM1. Leave it be.
No. Yeah, I think I'm going to leave it be, to be honest. The IVUS reassured me. And I think this is one thing about the point that Nadeem has said at the beginning. If I'm going to use the IVUS, I might as well get the information even before, because it will impact on how I'm approaching the lesion, how I'm approaching the case. Because I know that in this case, everybody was thinking the intermediate is going to be a problem, but luckily it's not. See, this is the problem with the angioscalp. They are a bit bulky. And now the 2 wires, I can't deliver it into the LAD, but if not, doesn't go, I'll take a normal. Okay, just give me a normal 3.5 by 15 or 20 non-compliant balloon.
Basically,
so yes,
in terms of the provincial standing technique, we always try to dilate side branch. So what's your suggestion?
Right. Okay. It's an excellent question. Again, the debate goes on. If I'm honest, and this is my approach on how I do my cases, if I decided that I'm not going to touch I'm not going to treat the side branch, I don't do anything to it. And also the business about you open the struts. The struts are open. The struts are not going to go anywhere. And if the side branch from the outset, I've decided it's not going to be treated, and sometimes occasionally even I don't even wire it.
Yeah, it'll be worse to create it. I believe you can. It gets worse rather than leave it by itself.
Yeah, I think actually one of the subsets of Excel showed the same, that if you actually open the struts to CERT and do a kissing balloon, you actually end up with more stent thrombosis later on.
It's intuitive. It's intuitive, isn't it? Because you're doing a puba. You're doing a puba. Go to 16, 18, 20.
And look at it.
You're doing a puba. Okay. We still have a little bit of restriction in the middle. With rupture, come down. Come down. The balloon has rupture, but that's okay. We'll do that. Need to make sure that we're okay here. Okay, good.
Do you have an NC? Did you put it with an NC?
That is an NC. They went to 20 atmospheres and rupture. So I'm going to take the angioscalp again and do the left main, and then we'll take a stent because I think it's ready. The stent will take the 3.5/10.
The question for this stent will be under expansion. So from IVUS, which show the almost circular severe calcification and the proximal.
Yes, pull this back. Yes, absolutely. And I said we still have a backup to do the IVL. You might have to stay with us for an extra 5-10 minutes, but if we need to, I think we'll probably be okay. And one of the advantage to my mind now with IVL, and I know it's off-label, but I won't be long before everybody's doing it. We feel a little bit more reassured, or kind of maybe falsely reassured, I don't know, that if you put a stent that's not expanded, you could use the IVL in it. Nobody knows what happens to the polymer, to the drug, but a lot of people are doing it, and it's not causing any major problem. I
am not
now,
sure
this is the angioscalp.
Yeah, I don't think we.
No, I don't think it's needed. I don't think it's needed. I think what we did here, slowly.
People like to do it. Everybody likes to hear about that, but it doesn't mean.
Yeah, absolutely. That's why I said that trend 16 and down. This, I think, there's a huge cost, a trend, absolutely, a huge cost to to the health system. And I don't know. This is what I was talking. Okay, go up there again. It's the importance of sizing the burr correctly. You can't use a 125 or 15 in a 4 vessel. And then, okay, well, it didn't work. Then you take the IVL. You could take a bigger burr and down, a bigger burr, and it'll be absolutely fine, rather than taking a burr and store that. Okay, now we could take a little picture and take a stent, and then we'll. So we got the stents ready. I think we'll do this in the areocranial. But let me just take a picture first. Some nitrate, please. We'll give some nitrate, take a picture and see what this artery looks like, and then we will be on our way to put the stent and hopefully finish the case for you on time so you could see the final outcome. That was 500 of nitrate.
What's the blood pressure right now?
Blood pressure is very good. 140, 160 over 72.
Got a lot. Yeah.
You can see it now.
Areocranial.
What
Turn your
you
head
are
to the left
seeing
for
looks
me.
fantastic.
It's very good. Excellent.
Well done.
So I think what we'll do is just to see the sizing. I think an 18 probably, maybe longer. Let's see.
Yeah, I would say more like 22, 20, 22.
Yeah, 20, 22. You're right. Yes, I think I might take. I don't have a because we chose the 23 might be too long.
Yeah, 20 is fine.
20. Okay, we'll take a synergy, a 50 by 50 by 20 synergy, please.
Yes.
Sorry, Monad, what was the diameter of LAD? Because it's quite big on the others.
It was about 4.5 to 5.
Yes, yeah, almost 5.
Yeah.
It's a big,
I mean, the left main is probably about 6. Yeah.
Yeah.
And often, I know this is how I do it. A lot of people do it differently. I usually take a bigger stent at a lower pressure and then post dilator than taking a smaller branch and having to go to a smaller stent and having to go to higher pressure. I don't know if that's something people do or not, but that's how I, because if you look at the compliance chart on most stents, of course, if you know the expansion limit and et cetera, if you go maybe to 6 or 8 atmospheres, you're probably the one step down from, if you take a 4O, for instance, and deploy it at 6 atmosphere, if it does expand, it's the same as the 3.5 stent. So, and then you could...
And most importantly, look at the LAD and circ. Or
yes.
LAD and diagonal, for example. It's exactly, but it's more half. They're in between. So
yes,
I think
absolutely.
it's perfect to leave it by itself.
Yeah. Yeah.
Right there.
Just one second.
Make sure.
So just gonna push this. Is this so? It might not be tested there. Okay. Store that and go to areocranial. Now positioning in the ostium, I could show you the technique I do, but I think we're okay here. We could see the ostium reasonably okay. I'm not too worried. In the ostium, focus on the ostium unlock. Okay, test there. Okay, perfect. Just PA cranial, store that. If you notice, I hardly take cine in here. The CTO has taught us to kind of conserve our X-ray and our dye, but test. Perfect. Okay. Okay, go up there. Go up to 8. Back to areocranial. Turn your head to the left, sir. Thank you. So again, once my balloon is up, I'll take store that 10, 12, and down. So you can see it's flush with the ostium. It's not a problem. Obviously, there has been all this noise about using the synergy and about causing a longitudinal deformation. I think it is operator related. If I'm honest, because I've seen it with every single stent. If 100%. You don't look after your stent, it is gonna get deformed. Synergy, so having the balloon in and it's just because we've seen synergy a little bit more angiographically, and also I suppose the design is a little different, so it might be more prone to. That's me then.
Yeah, people like.
We're gonna go up there. Just one second. Yes, Onyx is because it's a different design, a continuous wire, so it might be in theory, but I think any stent. I always say, if I'm honest, if you put any stent nowadays, put them in boxes and mix them and hand me any one of them, they all do the same. There are maybe 3-4% of cases where you need a specific stent to do a specific thing. Go up there. And that's a 10, 12, 16. Store that and down.
So this is a 5
So that's, yeah, 5 or 20.
Yeah.
So,
and when you finish it, I would dilate it a little bit distally, a bit distally.
oh God, yes,
to
yes.
take
We still
2.5.
come back. Test there.
3.5.
Yeah, come to be a codal. So yeah, so we'll get this guide in, and then we'll rewire the circumflex and reassess what's the best thing to do here. Okay, a little test. Oh, well, that's okay. Go on.
Right there.
No, just 1 second. I'll put that back on again. Oops. That's my wire being a bit, because you go to high pressure. I found this with the cyan blue. I don't know if you have the same experience, anybody?
Yes.
Where you,
blue,
if
yes,
you go to
that's
higher
exactly what we
pressure,
have.
the cyan blue, it just gets stuck.
Yes.
And if you're not paying attention, it comes back.
Yeah.
Particularly with the particular kind of wire of balloons. But yeah, I don't understand that phenomenon. Apparently, it's got to do something with the coating. But anyway, that's not an issue here. The LED is open and we're okay here. Okay, take that away. Can I have a fresh? Okay, I'll use that actually. I'll use that. I'll have a fresh cyan blue wire. Put the talker on for me, please.
Okay.
There we go. Hey, don't open it. Don't. Oh, it's okay.
You have
open
it.
That's fine.
Everything's here now.
Okay, here we go.
So
So here we go. I'm just gonna rewire the circ. Sometimes the temptation, even if it's symmetry, to leave everything alone, because the EBC trial has shown us even single stent with ballooning is enough test there. Okay, so you can see. Sure, I'm gonna take a cine here. Cine.
You're gonna cross it.
Here we go. I know. Yes, I think we need to both dilate a little bit more, but you could argue, so I could leave it, but because we did, you know, balloon dilatation and there's calcium and deformity, I think the chances of restenosis are high, and I think
That's
this will be a very
exactly
good
what
case
it is. You have to restudy it.
Absolutely. So I think we're in.
Perfect.
Again, I'd be interested to hear people talk about going through the distal strut. Of course, you try to go to the most distal strut, but unless you have IVUS or imaging guidance, you're not going to know where you are. This be there. Even it goes to this branch. It's okay. This branch is good too.
Wherever you are.
Okay. Okay. Can you give me a 2.0 by 12 normal balloon? Go back one for me.
For the circ.
So I'll tell you what, while we're waiting for the balloon, can have the IVUS. We'll just do an IVUS for the LED. Because I'm going to open the strut for the, have you got the balloon? It's okay, fine, give us, fine. Give me the balloon, 2.12 normal balloon. So I am going to send that circumflex. I don't think I'm going to leave it. Because I know at some stage, if I leave it now, we're probably going to have to come back. So we'll see before taking the stent, I will cross with the balloon and just open the, make sure that the stent will cross with me so I don't have to, I don't damage the stent going down. Fix that for me.
Yeah, a 2.5 is enough.
Yeah,
to cross.
Absolutely. Hopefully, I mean, I take quite often, I mean, even for pre-dilatation, I use a non-compliant balloon, but for this case, I use a normal balloon. See, it's crossed very nicely. Go up there.
That's beautiful.
Go to 20, 24. Store down. Okay, can you go to LAO codal? I want to see the osseous circ and see if you could. So now what I was telling you about this reverse T, now what I could do, because the stent is there and this is a synergy, which means we could see it better. I think you could position the stent in the circumflex osseum confidently, knowing where it is. But if I'm not, I could put the IVUS and see where I am. Can you see the angiogram? Here we go. I think I could position the stent without any problem. Can I have a 3.5 by
the left main LED is excellent.
Very nice.
Yeah, it looks very nice. A 3.0 by 12, or no, sorry, 3.5 by 12.
Circ, you don't need too much. Don't create too much with it.
Yeah, I think I'm just going to do a T because I said the thing with this stent right now I could see where I need to put my stent in the
Beautiful.
osseous circ. So you don't
I
have to
think,
be worried. And in fact, actually, you do not need to kiss because you
Yeah.
haven't crossed into the LED. I'll just
no,
do
no.
a final.
Yes, I think in this patient, leaving circumflex alone is not safe. I think it will definitely come back. So it
Oh,
has to be
absolutely,
stented.
absolutely.
Everything will
It-
come back. I can guarantee you 80% will come back, but you have to
And-
understand, redo it and lean it again, maybe 3 to 5
But
times.
Morris, they come back not because of the stent or the surgery, because they come back because of the disease. And I always say this to my colleagues and to the surgeon, it's not what we do, it's the disease itself. No matter what you do, this is a disease, there's no cure here.
Yeah.
That's the 4 o'clock chime, but I think we're going to be okay here. We'll get the stent and the...
Perfect. Look at
Okay.
this.
So, little test there.
That's
So now
why
I'm going to
it's
do
big.
this under cine, and that will show us where the stent, you could see how, I think that's perfectly positioned here. Go
So
up there.
are you doing reverse T or the mini tap? The tap.
No, this
Milita.
is T. This is T over. Okay. So when inject here, store that. Okay, down.
And dilated here.
And I'm going to have a 5.5 20 non-compliant balloon.
That's
Okay, go up there again. 12.
beautiful.
Store.
Well, we are finishing almost.
And,
Congratulations for an excellent.
Give me just a couple minutes. I'll show you the IVUS because I think that's important.
No, yes,
if
we have
that's okay.
we have 2 to 3 minutes. Yes.
Yes, okay. So I'll post dilate it quickly to the LAD. I'm going to take a picture here to show you what we've got. And we could IVUS it also. Look at that.
Look at that.
Angiographically, I wouldn't ask for any. Come to be echo.
Exactly. There's no
radiation.
need to go
So the
much
5.5.
higher.
So how far did you extend into the left main, Dr. Ingrid?
It's not into the left main. If you go back, go back.
From complex, did you go inside the left main at all or no?
No. Go back.
You're just
So
right
here
at
you
the
go.
off.
Right there.
So this
right.
is the beauty of this technique. Once you put your stent, if you're happy with your side branch, once you put your stent in the main vessel, it is a landmark where you could drop your osseous side branch stent. So as you can see in this view here that's playing, I could see, and if I'm not seeing it, I could go to 30 frame or to stent boost. And that tells me that they are kissing. It's not protruding to the left main. It's not away from the ostium, just perfectly on. Of course, you have to find the angulation, but if it's not, you could always use the IVUS, as I mentioned before. So I think it's a very brilliant way to avoiding, the bifurcate or, doing these complex and having to kiss and all the rest of it. But
So
that doesn't mean you don't do it. So I'm gonna just bring this back. Okay, go up there. Go up to 8.
Highest you can.
Door. 10.
So it's like a T stenting.
It is a T-stent. 12. That's proper T. And down. I'm gonna bring this to the left main and just go a little bit higher to 16 and think we'll be done by that and do the IVUS run and we'll be done. I could do the.
So no matter what, some of us will have to leave. Congratulations.
Of course.
Excellent presentation. It was fantastic.
Okay,
Fantastic.
go
Yeah.
there. Well, thank you. Thank you. That's 1 second. Nothing.
Yeah, I enjoyed it very much.
Thank you. Thank you for your comments. Absolutely spot on and really very helpful to see how everybody thinks and what they think of their, the approach. As I said, these are the nice, what you learn from people and what you see them doing everywhere is fantastic. But this is a 5055. Okay, here we go. Just do it coaxial and we'll go up. That's 1 second. I'll bring it back. That's 1 second. Yeah, go up there. Go up. 12, 14, 16.
Perfect.
Store and down. And this is why going back to the question I was asked earlier about the IVUS. When you go with 5.5 to 16 atmosphere or 6, so I think you're not going to do any more, even if you see that the stent is probably not as expanded or the stent is not. So we'll do the IVUS run and we'll absolutely. This is my final. I'm going to take a picture for you so you don't have to do it and do the IVUS, and that would be us done luckily on time in a good way. But here we go. Take that away. The wire has been pulled back a bit, but that's okay. That's fine. Okay, let's have the IVUS, please. Open up for me, Louis. Open up a bit. Open up, unlock. Okay. So here's the angiographic, final angiographic result, and we'll get the IVUS going for you. I'll get the guide in a little bit more at the end, but so can you put the camera on the IVUS, please? Okay.
Beautiful.
Thank you. That's it's gonna come in. Come with me.
Look at this.
A huge left main.
Huge.
This is the LED.
Oh, this is the LED. Oh my God. One,
yes,
two,
we're starting from there. Yes, I know.
You see how it looks?
Almost five.
And
yeah, everything
well,
is close to 5. Yes.
So we're gonna come to the area of heavy calcification, but the cross-sectional area here is gonna be huge.
Yeah,
it's
huge.
very well expanded, very well deployed and opposed. I don't expect any further than this. I go higher pressure, you could run into trouble. Here comes the circumflex.
Leave it alone.
And I think this cannot be any better, to be honest.
I think
you don't expect any. Here goes the osteocircumflex coming in here, and here's the 2 wires.
Circumflex stents, actually, if you can.
Sorry.
The osteocircumflex.
Yes, I will.
Stents.
I will. Do you want me to do an IVUS to the osteocirc?
No, I don't think so. You need to.
No need.
I don't.
No need.
I don't think
no need. It just
because
absolutely.
It looks so good. Don't create a problem.
The osteocircumflex.
Absolutely. I absolutely agree.
Congratulations. Fantastic.
Right. Yes. Why don't we go for the next presentation, if it is okay? Thank you so much for sharing.
Yes. What I'm going to do, sorry, just one second. I'm going to go to my office and just join you on my laptop.
Yeah, sure. We can come back and see your final results if you need so. So that's fine.
If that's the final result, I'm not going to do any more.
Okay, good. Thank you so much for this. Wonderful, and congratulations for this case.
Thank you, guys, and thanks for the comments, and thanks for everyone in here and for the AV guys, because they've done a fantastic job. And yes, I'll join you shortly on my laptop.
Thank you, Murad. Wonderful.
Listen to the Okay, I'll see you soon.
Next, thank you. And we go to the next presentation, Dr. Athar Ansari.
Thank you, guys. Do you want to take the
left main PCI in cardiogenic shock? Dr. Athar, are you ready with your presentation?
Everybody, salam alaikum, and excellent. Thank you very much for inviting me. I'm very excited and honored to be here from San Diego, California. And I just think it is amazing that we have an international meeting from China to UK to Pakistan to US, and now Maurice is sitting in Minneapolis. I hope Maurice is still listening to me. But I wanted to tell us about our practice. So I practice in Southern California in a town called El Centro, but I also practice in San Diego. So it's about 122 miles apart, to be exact. And so we have cases coming over we do some peripheral cases in a small world. So El Centro could be akin to like Chichu Ki Malian or Shikarpur in Pakistan. It's a very small town, about 50,000 people. So we had this patient, so this is the background, and we have this patient, can you put this slide, who has been transferred from El Centro. We have seen this patient in the office earlier. Go to the first one. Yeah, yes, this one, first one.
Athar, we have to continue and finish your all.
Yeah, so we finished this office. So this is a patient who is about 74 years old and comes with a non-ST elevation MI, and then is transferred to San Diego from El Centro. Next one. And so he's stable. His blood pressure is about 120/70. He had a previous PET scan, had shown an ejection fraction of 45%. And at that point, we transferred him to one of the tertiary hospitals, which amazingly does not have a surgical backup. So the tertiary hospital, San Diego, is a PCI able patient, but without any on-call surgical site. So next patient. So we go to, so this is very much what Nadeem Rizvi was calling about what we do in a poor country like Pakistan. So I think this is exactly what I want to tell you about how you would handle this patient. So no, first one here. So this is the first angiogram. He's come over, he's pretty stable. Number 4. Number 4. So number 4, let's go to the next one. Next one. No.
Yeah, okay.
And escape. Excuse me for a second. I'm just getting to the right slide. Go play the angiogram. So this is echo. Excuse me, let me go back. I'm just going back. Excuse me for 2 seconds. I'm going reverse. Okay, here we go. So this is the first shot you get. Let me get in full screen mode. Can you see it?
Yes, we can.
Can everybody see? So this is a surprise. Patient has a mild troponin rise. He's stable, 120/70 blood pressure. And this is the first shot. What do you want to do, guys?
Can you play the shot? Yeah, please.
I'll play it for you.
What are the hemodynamics of the patients? The blood pressure?
At this point, pressure is about 110/70. Heart rate is about 90 beats per minute. Patient stable. What do you want to do?
Yeah, I think the first thing that we see quite a lot of these patients, I think it's not a very good idea to just open it, because if at the moment the patient's stable, I'd put in an IABP air, and then I would just do the left main, just open it up with a balloon and then take things from there. Some people would probably just go ahead and intervene and then wait for the hemodynamic collapse, but that would probably be too late. So my suggestion is, in Pakistan, we don't have Impella or the thing, but I think if you want to support, the best thing is to put a balloon pump now and then just do the case.
So you will do a proactive approach, put a balloon pump at this point.
Yes, I think the way this left main looks, it's serving around 80%, 70-80% of the myocardium is being served through this system. So I would probably not wait. I probably expect the right to be a small vessel.
Anybody else?
I think in an ideal world, definitely for this sort of a lesion, probably check the EDP, go for Impella for sure, and then maybe do PCI from the same sheet. Definitely Impella if available. Otherwise, balloon pump, yes and no. I'm not sure what a balloon pump is going to do right now when hemodynamics are stable. But maybe keep it on standby. But if available, Impella is the one which I'll probably use.
So that's the right coronary artery on this patient, non-dominant and small. So would anybody go for surgery? It's a patient is stable, or you would leave the patient alone for open heart surgical consult, or no?
I think at least should be discussed with the heart team approach.
Would be heart team. So just to make things go, okay, so do it. Some people say maybe just discuss
What's
the heart.
the troponin like? Has he had a leak? And
yeah, he does have about not a huge one, but 17, 18 troponin.
Yes, so if it's an ACS, I think surgery would probably not be a very good idea. And these kind of patients, by the time they get opened up, they probably lose a lot of micro.
This is so as we are talking, I just put up he's stable to get an LV function. So a little bit. Let me excuse me. And that's his LV angiogram. You can see nothing is moving, but he's still talking. Okay, so anyway, so question is to do a balloon pump versus surgery versus not. So I did call the surgeons just to let him know because he was stable, and I made a phone call. So as I was doing it, the patient crashes. And the blood pressure goes down from 110, 120 to about 70. Saturations drops to about from 95 on 2 liters to about 70, 75 very rapidly. He's in an acute pulmonary edema, I think just from the contrast dye. So what's the next step we should do now? Put a balloon pump. Put a balloon
In
pump.
Pakistan, we would ventilate him straight away, put a balloon pump, ventilate, and then just go ahead and open the.
I think, yes, I'm from Lahore, so you read my mind. So that's what I would do, ventilate the patient. I think that's important, not to forget the airway. The patient is bubbling with pulmonary edema, so that's what we did. And simultaneously, we decided, rather than the balloon pump, put an Impala device from the left side. So within the next 7-8 minutes. So this was the left side approach. Patient was done from the right side, the Impala. And then next one followed by, so you need to do a wire and do a PCI. So I heard all the discussions and about the cost and everything. So, but in this scenario, you have a very sick patient who has just turned around an acute hemodynamic collapse. You need to act very fast, and you cannot have so much discussion. So we elected to start over his case immediately with a guider and putting wired the left main to the LAD and to the circumflex, as we discussed on this long elective case, what we do. With the exception that all the technologies, rotablator is not a choice. You don't have that kind of a time. You have to act within the next 15, 20 minutes. But having said that, the Impala, here you can see the Impala done, is a fantastic thing, and it will save lives. It makes you a little bit more comfortable that you can proceed with your intervention. So I ended up wiring both left main LAD and exactly what we discussed before. Rather than I was saying it, we have to act fast. So we ended up, I'm going to go faster for the sake of time. So I think there were comments made about pre-dilatation or not. And I think Professor Shen mentioned he would not pre-dilate most of the things. I did. I use all the time pre-dilatation with non-compliant balloon. Although it was a very calcified vessel, in the sake, and there was no time to set up a rotablator. So just we put a quick poor man's technique, thinking that I'm in a smaller town. So it's 2.5 millimeter balloon for both the circumflex and the LAD. And next thing is, and followed by, once there was a delivering of the stent. And the stent is into the left main to the LAD, covering the circumflex. Now, remember, the circumflex has been pre-dilated. So I was pretty confident that I can do what we did in this case by Dr. Engrid. So here we go. And this is the stent deployed. Next patient. And finally, there's more. And then I put a second stent using kind of the same concept of T, just getting it right across with this left main stenting and the LAD stenting, and then making as a marker and putting the second stent. So you can see it's right there, maybe abutting a little bit to the left main, I cannot swear, but this was, I'm not doing any IVUS. So next thing is, this is a circumflex stent. So I don't have to do any kissing or any other fancy work. We want to move around, and you got both things covered very quickly and a flow. And finally, to finish it off, I put a small, I thought that I might have missed the ostium of the left main. So put a small, another third stent, which is right there. Pull the wire back again. And so the patient has on echo prior to the procedure, ejection fraction of 10% with a 4+ MR. So it was all ischemic MR. And he collapsed because of global severe ischemia. So you can see very quickly acting could save a life. And finally, this is what we got at the end. I'll show you. And then we finally got a patient. Here we go. the left main LAD. There's some disease on LAD diffuse here, which I left alone. I didn't want to be too fancy. And here we go. That's the final picture. So patient immediately with a smart assist Impella was doing about 3.5 of cardiac output. I was able to wean it off, get the patient right there. I think we were done in about 25, 30 minutes, all this whole case finished. And he was transferred and then I think discharged we were able to take the Impella out in about 3 days. His ejection fraction improved completely, and I will show you his follow-up. Here we go. This is a follow-up on discharge. His EF is about 45 to 50%. So the point I'm trying to prove is that although we have all those fancy devices, and it's good to practice in that way, but always don't forget that the basics need to be covered, and you can act fast and use some modern technology, and not to forget the basics of intubation, ventilator, and then do your PCIs very quickly. We were able to get a big lumen. I post-dilated the left main with a 4 millimeter NC balloon. There was no plaque shift, and the patient followed up, was discharged 3 days later on, and did amazing. So that was my quick presentation. Any questions?
Okay, thank you so much, Athar. Can we just remove the slide so that we can have a question-answer session for about 5-6 minutes? Now, the question is, my first question is that in this scenario, when you have a very little reaction time, and you are thinking of having 2-stent techniques, so I will ask the panelists one by one that what will be their choice, the quickest way to have 2 stents technique, which technique should be followed in this scenario. So we start, any volunteer from the panelists?
Yes, can I just make a comment, Athar? I think this was a case very well done, and I think you saved the patient's life. My only question is that I would probably be, you were very brave, I would probably in a left dominant system, I would like to make sure that the left circumflex is preserved. So I would definitely do a left, as a DK crush in this, where put a stent in the left circumflex, crush it, and then put a stent in the LA. Because in this case, you put a stent across the left circumflex, and in such a collapsed patient, and we don't have Impella here, and getting back into the circumflex in that kind of scenario, if the flow had gone down much further, and you said there was MR and something, I think you were very brave putting a stent. It's kind of a provisional thing that you did. I would probably protect the left circumflex and put a stent in, and then do a DK crush.
So I think that's an excellent point. And what we decided to do was, sorry, go ahead.
I was just going to make a comment about one of the
no, it's okay, fine.
One of the techniques, obviously, is the shotgun angioplasty. I know a lot of people don't do it, and they think it's probably not, and I don't use it, but in cases like this where you are a little concerned and there is a concern about losing a dominant circ or any of the branches, the shotgun technique is brilliant and makes life very quick and very easy as a bailout.
Yes, especially if the left main is not very long, so you can do simultaneous kissing, and that is
that's called the
quickest, I think, way to get away with truth. Let's Sean, what do you think, which is the best technique in a when you have a small reaction time and we have to make a crash? But let's see your views. Unmute your mic, Sean. Your mic is not on.
I'm here. Yeah, I'm here. Actually, to be honest, I think no best answer for the question about how to select standing technique. But in general, personally, I have 2 more comments about these 2 cases. The first is final kissing should be done after any kind of 2-stent technique. I think this is the key to avoid the occurrence of stent thrombosis. Secondly, because I always stratified the bifurcated lesion according to the definition criteria. So both these cases are classified by complex bifurcated, complex distal left main bifurcated lesion. So I fully agree with the comments from Karachi about the use of DK crush.
Okay, thank you. Any comments from anyone else?
So can I make a comment here? just to follow up the summarize.
Yeah, sure, please.
Yeah, so I think
Sure.
the comments are well taken, but I think the important thing, I think if I have not emphasized, that we did wire the circumflex and to preserve it initially, and the left main LAD. And then I always use, this is the way we have been doing it, myself and Maurice, we do a pre-dilatation with an NC balloon and usually use a 2.5. So that, and because of the idea when we put a stent in, we will have an access to side branch. So we use double wire, then stent the left main LAD, but pre-dilatation of both. So you saw that was a subtotal left main LAD. There was nothing there. So once you pre-dilate, you establish flow, you got some blood, and then you have much more, you are more relaxed. And then once you've done your stent into the left main LAD, then we remove the wire and then rewire through the struts. And then we do the common T, or you can call it a kissing crush, because the when you do the NC again in the left main LAD, you make sure that small amount of if the strut is into the butting into the left main
Yes.
is also crushed. So it's
Right.
kind of a modified Shen's technique, which I and with without using an IVUS.
Thank you. Sir, this was a wonderful case, and you really saved the patient's life and a good service to the patient. Now we have just 6 minutes for the concluding remarks. If I can request Professor Chen to show and to summarize what we have done today. Thank you. Professor Chen, please.
Well, thank you, Officer. First of all, it's my great honor to learn much more from these two live cases. And also, I think it will be a very good opportunity for me to share our knowledge and to communicate with all my friends. In terms of the distal left main bifurcated lesion, I think even there is no dedicated stent technique to be recommended for distal left main bifurcated lesion. For example, for 2018 ESC guidelines, so which recommended provisional stenting technique is good, but for distal left main bifurcated lesion, so upper front two stent technique could be preferable. So my only one sentence is that to suggest to all my friends that before stenting technique for any kinds of complex bifurcation, we have to very carefully analyze the anatomy, the plaque specificities, particularly for distal left main bifurcation. Thank you. Thank you.
Thank you so much, everyone. So I really obliged for all the participants, panelists, and particularly Mohammad Agrid, who has shown us a wonderful case, and also Atar Ansari. And I'm thankful to all the panelists and the last but not least, the audience. And thank you so much. So we finish our session today, and we'll meet maybe in next 3 months. And last, before we go, I must be very thankful to High Noon Pharma, who actually supported this event under umbrella of Pakistan Society of Interventional Cardiology and Pakistan Cardiac Society. And we will continue this quarterly program, and the next will be hopefully somewhere in September or October. And thank you so much for joining us today. Bye-bye.
Officer, thank you yourself. Thank you for organizing this and for the really fantastic work you've put in, you and your group, whoever's been involved in organizing this. And thank you for having me and give us the opportunity.
Thank you so much. Bye-bye.
Thank you.
Thank you.